As South Africans, we can all agree that medical care is expensive, and if you're on a private scheme, it's getting even tougher to afford. With about 85% of the population dependent on a crumbling and inadequate public health system, can the National Health Insurance Bill, which is a seeming reality by 2026, be the cure-all? According to Dr. 𝗧𝗵𝗶𝘀, it can be. He's taken on the mammoth task of setting up the NHI's administrative and operational capacity for the Department of Health, in what will become the hub for South Africa's healthcare solutions. The bill has been drafted, it's been presented before Parliament, but it's also come with a lot of criticism. Do you feel like you've been handed a hot potato?
Look, any major reform of any description is bound to have opponents, it's bound to raise anxiety. There's a lot of suspicion of things the government have done, but hot potato, no. This is something that I've been wanting to be involved in since the late 80s, and I'm very excited we've got to this point.
Russell Rensburg, director of the Rural Health Advocacy Project, believes that universal health care is a necessity, especially for 38% of South Africans who currently have difficulty in accessing medical care.
You know how many kids sit in a classroom and they're made to feel stupid because nobody tested their eyesight. Now we have a school outreach team that comes, tests you for your eyesight, and within 2 or 3 weeks you have access to a pair of spectacles. And your whole development trajectory changes. Health is a foundational element to broader human development.
Topographical challenges in outlying areas inhibit access to quality medical care, and 95% of people in rural areas don't have medical aid.
What we liked about the NHI was a number of different things. It creates another formula that looks around what are the health needs of those particular population. If it's too many young women, how much money is there for reproductive health services? For us, it looked like a better way to fund healthcare.
This year, the Department of Health estimates that around 222 billion rand will be spent on public health care and approximately 250 billion rand in the private sector, which only serves about 15% of South Africans. According to Dr. 𝗬𝗵𝗶𝘀, Deputy Director General for the NHI, the bill proposes to aggregate these funds into one large pool.
We think we can spend less than 480 billion and give everybody a great package of services relative to what they're paying now, and for them to pay less for those services.
Dr. Johan Serfontein consults to the South African Private Practitioners Forum. He emphasizes that at the current economic growth rate of 0.6%, these funds will not be adequate.
The Davis Tax Commission report in 2017 indicated that unless South Africa has significant economic growth sustainable year on year of at least 5%, there's no way that we can implement universal health coverage.
Government says there is money available. Over and above the current health budget, by 2026 NHI will be funded through a combination of taxes: general tax, a surcharge on personal income tax, payroll tax, and a redistribution of medical scheme tax credits. But estimates by economists of how much funding is required to implement NHI annually in actual rands and cents are wide-ranging.
They even have raised figures of 800 billion. And all of these figures are based on the assumption of the costs in the private health sector currently. What people have not done is recosted the model based on the way we've proposed it.
At the moment, the way in which the fee structure works in the private sector is on a fee-for-service. So you get an itemized bill from your medical aid. So by listing 5 or 6 different codes, the patient will not know, except if you're a health practitioner, whether those codes are justified or unjustified.
The way the rest of the world is moving to decrease overall medical costs is to pay for the outcome, like a hip replacement, not individual items, for example, the suture or plaster, that tend to drive the costs up, and the NHI plans to do the same.
Let me give you an example. A relative recently was quoted 33,000 rand for a dental procedure, which involved removing 2 teeth and doing a whole host of itemized things on this bill. There's no way I was going to accept this itemized quote for this procedure, and asked a dentist whom I trust to give me an opinion on the quote. Without going into the details, the procedure was done, finished, for 1,800 rand by the dentist.
NOAS.
One of the mechanisms that is there is for hospitals to be paid what they call a DRG, diagnosis-related grouper, which is like a lump sum for a patient to get treated for a specific condition. It implies that the doctors working on this patient are also employed by the hospital. And doctors don't want to be employed by hospitals. The hospital starts putting pressure on you to practice in a specific way.
Many aspects of the NHI still remain unclear, especially for the private medical industry. One of the main concerns amongst specialist doctors is the uncertainty over tariffs and operational cost issues. The threat is they may choose to just close shop and head for greener pastures.
If you do it rapidly and you just cut somebody's income off on next month, then that is the result you're going to get. So that's obviously not the responsible way to do it.
Healthcare professionals want to work in an environment where if you set up a practice today, which is very costly, you know that 10 years from now, you'll still be able to cover your practice cost.
The NHI aims to shift certain services. So first, you would visit a primary healthcare practitioner, like a GP, who then only refer you to a specialist if necessary.
So you push the cost down and you make the highly specialized people more available to see to the genuine problems.
What makes the NHI's funding model feasible, according to the Department of Health, is economies of scale. So if everyone comes into the pool, then the NHI pays less for services, including medications.
You will access services based on your clinical needs. So in other words, next year I'm very sick and I need to see the doctor very often, but the year after maybe I wouldn't see him once.
So who will be in charge of the billions in the NHI coffers? The Minister of Health, of course, who in turn will appoint 11 board members to oversee the entire NHI entity. 𝗀𝗏𝗃𝗀 is a legal researcher for Section 27 that advocates access to healthcare services. They support the NHI and have been monitoring the bill since its inception.
The amount of power that is given to the minister is quite a lot of power. And we just think that there's a lot of room for political interference because there's not a lot of oversight from other independent bodies such as parliamentary committees.
The National Health Insurance Fund is what we call a Section 3A public entity. So it must have a board, it must have a CEO. Why is the minister appointing these people? The minister is effectively like the CEO of the health system.
Remember that that's what happened at Eskom, that's what's happened at the SABC, so that doesn't necessarily give people comfort.
The board members, before appointment, must be interviewed by an independent panel and publicly interviewed so everybody can understand who are the potential candidates and then have a sight of what the shortlist would look like.
The bill really just makes a provision for accountability at a very high level. We should also just be looking at the health system in general to see where have we been failing in terms of governance and accountability and transparency.
It is foreseen that medical aids as we know them may no longer exist. The bill proposes that medical aids will cover complementary services not offered by the NHI. That's the theory, at least.
Whatever is covered by the full package of the NHI may not be included in a medical scheme. Anything that is an exclusion, that is what medical insurance or medical schemes will be allowed to cover for top-up, or you can pay for it cash.
It could also mean a service rendered by a private practitioner who isn't contracted with the fund would also not be paid for by the NHI fund, and the medical scheme may be able to cover that as well.
When it comes to exclusions in the NHI, illegal immigrants and asylum seekers will be worse off. They will only be eligible for emergency care and services relating to notifiable diseases such as TB.
Currently, everyone in South Africa is able to access HIV treatment if they need it, regardless of their status. Even though we're acknowledging that the resources are limited, we still really need to think about that public health benefit.
The public participation phase is on, so now is the time for South Africans to have a say. Although there are many public health facilities that are centres for medical excellence, others are in urgent need of attention. But under the NHI, only those that comply will be able to service the system.
The purpose of complying is to make sure that we systematically improve the quality of what happens in the facilities. That includes the physical quality of the building, the clinical quality, medicine availability, everything.
2026 is the year that everything is supposed to come together. Do you see that happening?
I don't think realistically we can expect anything of this nature before 2056. I think there's just too much that needs to happen. There's too much uncertainty.
But Dr. 𝗀𝗃𝗃 is a man with a purpose.
We will set up the nucleus of the office by January next year. We hope by the time we have the administrative and operations in place that people like me will be able to leave our medical aid knowing that we're going to get good health care in the new NHI system in 5 years' time.